Everybody, I'm here to give a very small gist on the very important and highly scoring topic on orthopedics, which is the orthopedic oncology. So let's start. So among all the questions that we get, the most important diagnosis, the most important they say, what will be the gold standard investigation of choice compared to investigations like CT, MRI, radiological investigations. The best thing you could answer is always a biopsy. Whatever the bone tumor you're getting, always answer biopsy as the gold standard. Okay. Then we have periosteal reaction. What is periosteal reaction? The reaction of the periosteum covering the bone to an insect is called periosteal reaction. We have X-ray features for this periosteal reaction. In Ewing sarcoma, you get onion peel appearance in Ewing sarcoma. And in osteosarcoma, you get something like a sunray appearance, a sunburst appearance. And then we have a Codman's triangle. Okay, this is all because of periosteum. And in osteomyelitis, the periosteum becomes very thick, as in forming involucrum sequestrum. Okay. Then we have sites of bone tumors. It's very important you remember this. Mostly it will be around the knee, especially more distal femur is more commonly involved than proximal tibia. It's the most common site overall. And proximal humerus could be there. You can also get tumors in the small bones of your hand and feet. That is enchondroma. And in spine, you're getting 3 tumors. Remember it as HOM, H-O-M. Hemangioma, osteoblastoma, and METS, multiple myeloma and METS. These are seen in spine. So based on the location of in bone, we classify the tumors. So mostly we know all the tumors mostly will be in metaphysis because it is the most vascular area in your bone. So all the tumors that we see will be in your metaphysis. So just remember the other things that will be in epiphysis and diaphysis. Just remember the clue ECG. So epiphysis has got chondroblastoma and giant cell tumor. Chondroblastoma is seen in children. So there will be growth plate will be visible in chondroblastoma. And but in giant cell tumor, there is no growth plate. Then in diaphysis, which is the center of the bone, mid-thigh swelling. If these questions are coming, just remember you have Ewing sarcoma, osteoid osteoma, adamantinoma, and fibrous dysplasia. Remaining everything would be in your metaphysis. Okay. In classification based on the age group. So the tumors which are seen in kids 5 to 25 years is most commonly Ewing sarcoma. The question on Ewing sarcoma would be like a 10-year-old or 15-year-old boy coming with a mid-thigh swelling, with mid-leg swelling. So always remember 5 to 25 years old, it is Ewing sarcoma. Somewhat younger, teenagers, 10 to 20 years old, then you get primary osteosarcoma. It's the most common malignant bone tumor in children. In our age group, in adult zone, 20 to 40 years, they are giants. So they get giant cell tumors after skeletal maturity. And again, older ages like parents, 40 to 60 years, they get secondary osteosarcoma. And the secondary is because of Paget's disease, radiation, and teriparatide use. Chondrosarcoma could also be there. And after 60 years, you get METS, multiple myeloma, adamantinoma, and chondroma. So METS and secondaries, the most common malignant bone tumor would be a metastasis. And the source is from CA breast, CA prostate, and CA lung. The most common location of that metastatic tumor would be a lumbar vertebrae more than the thoracic vertebrae. So what will be the characteristic of a secondary bone tumor? These can be purely blastic or purely lytic. The blastic is seen in prostate, medulloblastoma, and carcinoids. And the lytic phase is seen in kidney and thyroid cancers. And breast has got both lytic and blastic, but primarily we'll be calling it lytic. Miscellaneous, important one question, one lines. So the most common primary malignant bone tumor. So in malignant bone tumor, primarily just originating from the bone, it's multiple myeloma, more than osteosarcoma. Just answer multiple myeloma. So most common primary non-hematological bone tumor would be osteosarcoma and again chondrosarcoma. Most common benign bone tumor, the benign bone tumor is osteochondroma or exostosis. But this is not a true tumor. So if the question asks, that's the most common true benign bone tumor, it is osteoid. Let's see fibrous dysplasia. So fibrous dysplasia is the development anomaly of the bone. The bone is replaced by fibrous tissue and bone marrow. It's more commonly seen in your femur. So what happens? The bony tissue is replaced by fibrous tissue, riven bone, so ground glass appearance. And a rimmed sign. You have a dense rim around the fibrotic tissue. You have a dense rim sign. And because of the replacement of bone by fibrous tissue, it just crooks around so much. So just ends up appearing like a Shepherd's crook deformity. If you are taking a biopsy and seeing the fibrous dysplasia, so it's dysplastic. So the cells will be dysplastic, looking like Chinese letters. A Chinese only writing Chinese letters. So that's it. And you have variants. It's mono-osteotic fibrous dysplasia or polyostotic. You have an important syndrome associated, which is called McCune-Albright syndrome, which is all P's. One would be polycystic fibrous dysplasia, second would be precocious puberty, and a third would be pigmentation, capillate spots. Okay, This was all about fibrous dysplasia. Remember the ground class appearance, rim sign, shepherd tooth deformity, Chinese little appearance. Then we have bone cyst. We got simple bone cyst and aneurysmal bone cyst. Simple as the name suggests, it's unilocular. It has got a symmetrical expansion and eccentric. Aneurysmal bone cyst is multiloculated, asymmetrical expansion, eccentric. They are in metaphysis and they are in 10-20 groups. Most commonly simple bone cyst is simply around your hands, proximal humerus. Aneurysmal is around the knee. Simple bone cyst has got clear, straw colored fluid as a cyst, but aneurysmic bone cyst has got hemorrhagic fluid. How do you manage a simple bone cyst? Aspirate the cyst, and injection of steroids is sclerosins, sometimes excision curettage of the autologous bone graft. But aneurysmal bone cyst, you have to do extended curettage. Extended curettage of the cyst is done, and it's adding, you get liquid nitrogen, a bone cement, and phenol. These are all done to treat aneurysmal bone cyst. This extended curettage is done especially for two tumors. One is the aneurysmal bone cyst, and another would be your giant cell tumor, osteoclastum. So how does a simple bone cyst look? Look at here. If simple unicameral simple bone cyst, you just have a simple hypoejaculation. Whereas, and sometimes the cortex falls off, it looks like a fallen leaf sign. Okay. Whereas in aneurysmal bone cyst, you get multiple loculations, multiple septi in your metaphysis. That's called aneurysmal bone cyst. Then we have another tumor, that is the osteochondroma or exostosis. It's actually not a true tumor because there is no malignant potential. Usually, from the epiphysis, osteochondroma, epiphysis grows towards a metaphysis. What happens in osteochondroma is that instead of growing towards metaphysis, it grows outwards. It grows away from the joint line. It grows outwards. Usually, this is asymptomatic. Osteochondroma, it is usually asymptomatic. Exostosis is not actually a bone tumor. After bone has attained skeletal maturity, it stops growing, and the cap would not be that much visible. It's less than 2 centimeters in size. But one thing that should always be threatened of is its malignancy transmission potential. It can change into osteochondroma, can become chondrosarcoma. So that's why. How do you know what are the signs, warning signs it's becoming chondrosarcoma? When you're getting the cap more than 2 centimeters in size, and on X-ray you're getting heavy calcification on your X-ray, and even after the skeletal maturity, the growth is still persistent. Even after the child is more than 18-21 years of age, the growth is still persistent. This is the signs that you know it's becoming chondrosarcoma. How to treat it? Extraperiosteal excision at skeletal maturity. After the skeleton got mature, I'll just take the extraperiosteal excision of this extra growth. So this was about osteochondroma, exostosis. Then we have something called as the enchondroma. Enchondroma, it's just along the small bones of your hands and feet. So that will be metaphyseal. You have a lucent lesion in metacarpal bones. How to treat it? Extended curettage and a bone graft is kept. And we have two syndromes, Maffucci syndrome, Ollier syndrome. Maffucci syndrome, Maffucci means it is multiple enchondromas, and Maffucci many, so you have multiple enchondromas. Not just that, you get hemangiomas, lymphangiomas, cavernous hemangiomas and lymphangiomas. Whereas Ollier's only enchondromas, multiple enchondromas. Okay. Then we have chondroblastoma. Another name of it is Codman's tumor. Chondroblastoma is called Codman's tumor. Remember, Codman's triangle is seen in osteosarcoma, whereas chondroblastoma is seen in Codman's tumor. We have osteochondroma and this is chondroblastoma. This is an epiphyseal lesion. We see ECG, giant cell tumor, chondroblastoma. It's an epiphyseal lesion most commonly seen in children 10-25 years of age before the skeletal maturity. So how do you see it in X-ray? In X-ray you see a punctate ostiple calcification in your X-ray. In the biopsy findings, a chicken wire calcification. If you are able to see the chicken wire calcification here, so chicken wire calcification is seen in your biopsy. Next we have osteoid osteoma. It's the most common true benign tumor. Osteochondroma was a false benign tumor, whereas osteoid osteoma is a true benign tumor. It's in children, adolescents and in diaphysis. Its most common location would be a femur. Okay. The clinical features of osteoid osteoma that we should always be knowing is that it has night pains that responds best to salicylates like aspirin. You have a central lucent nidus is in 2 cm and surrounding sclerosis. NSAIDs are the best for pain relief. We can give radiofrequency ablation for reducing the tumor growth, and we can sometimes give MR guided focused ultrasound destruction, extended image. Then we have giant cell tumors or osteoclastoma. These are locally aggressive. It extends from epiphysis to metaphysis, and it's more commonly seen in females than in males and in the R age group, 20 to 40 years after skeletal maturity. The clinical feature of this on X-ray you'll be seeing eggshell crackling, and this is more common in your knee region, the distal femur, then proximal tibia, and another one classical area would be a distal radius. Around the distal femur, proximal tibia, we get many tumors, but one classical tumor, one classical location for osteoclastoma would always be the distal end of your radius. How do you see it in biopsy? In biopsy, I'll be seeing multinucleated osteoclast-like giant cells surrounded by mononuclear cells. I have multinucleated osteoclast-like giant cells surrounded by mononuclear cells, and the tumor cells are stromal mononuclear cells. How do I treat it? We saw extended curettage is done for unusual bone cyst and for osteoclastoma. So extensive curettage, and you have to add adjuvant therapy like liquid nitrogen, phenol, argan beam, H2O2, high-speed pump. So local recurrence is seen in osteoclastoma, giant cell tumors, 20% recurrence is seen, and the risk of malignant transformation is 5%. An important thing to note is that osteoclastoma has rebirth methods to lungs, so always check for the lungs in patients. We have variants like non-ossifying fibroma, aneurysmal bone cyst, closest resemblance, chondromyxoid fibroma, chondroblastoma, fibrodysplasia, simple bone cyst, Brown's tumor, osteosarcoma. Hemangiomas most commonly occurs in your elderly population. It's a benign, asymptomatic vascular tumor. Hemangiomas, we saw HOM. Hemangioma is going to be seen in your spine. So this seems like a jail bar. So this is your spine. It comes like this. So it's a jail bar, jailhouse, or corduroy appearance. And on your CT MRI, you get follicle downside. Okay. Osteosarcoma. It's the most common bone tumor in children. It's a radiation-induced bone tumor. It is induced by radiation, but it is most radioresistant tumor. In your X-ray, you get a sun ray, sunburst, and Codman's triangle elevated periosteum. Presentation is bimodal: primary osteosarcoma, secondary osteosarcoma. Location is metaphyseal, distal femur, then tibia. How to manage it? Because radiotherapy is not all user. First, get a neoadjuvant chemotherapy, then surgery or limb ablation, followed by an adjuvant chemotherapy. The chemotherapeutic agent that we're using here is by T10 protocol. Important one would be high-dose methotrexate, doxorubicin, vincristine, actinomycin, bleomycin. And the last one we're going to see is Ewing sarcoma. Ewing sarcoma is resembling infection in many aspects. So it's the most common tumor in the primary and first decade of life. In the first decade, you get Ewing sarcoma. It's in males, diaphysis, a mid-thigh or mid-leg swelling. The poor prognostic factors are METs, and if you're having fever, it's a poor prognostic factor in Ewing sarcoma. The clinical features at presence like an infection, mid-thigh or leg swelling, signs of inflammation, incidental stiff trauma. X-ray got onion peel or lamellated appearance. MRI is done prior to rule out infection, determine the extent, and plan biopsy. Biopsy is the best investigation. You get small round blue cells with pseudorosets. Pseudorosets appearance and small round blue cells. You have PAS positive and digestible tumors. And you have CD99, MYC2 CD99 on immunohistochemistry specific marker. And in karyotyping, you get translocation of 1122. So these are the 4 important features in biopsy that you have to know. In Ewing sarcoma, you get small round blue cells in a pseudoresit arrangement, PS positive and diasis digestible, MYC2 CD99, and karyotyping you get T1120 mutation. Translocation. How do you treat it? Chemotherapy is important. Limb salvage or limb resection, you can give adjuvant radiation. It is radiosensitive, but radiotherapy is not generally preferred here because there is increased chance of recurrence and secondary malignancies once you give radiotherapy. So this is all about the bone tumors. Hope you got an insight. Thank you.